So now, any questions before we go on to the next step, which is a little bit of the research that's behind the original scoring? Anybody have any questions at all? Was this helpful to get a sense of the history of this? Okay, good. Now, there was a group called the Society for Nutritional Oncology Adjuvant Therapy, or NOAT. Like, I know it's important, you know it's important. And you can see some of the people that you've already met, the two Sues. And actually, this was our validation of the scoring and triage schema. And if you see the 9601, it was the first study of NOAT, and in 1996. So that's what those numbers mean. The specific aims of that were to form a feasibility, to address ease, cost-effectiveness, applicability, to validate the scoring and triage, and to assess its clinical relevance, and then to assess the patient distribution, understand the patients that we included. Now, the study criteria basically was all based on a volunteer research network. Most people who do clinical trials, you have to have lots of money, you have to have a big budget. All of this research that you're seeing here was done with no money other than the postage. What would happen over the years when I was lecturing is people say, this is so exciting, here's my card. If there's anything I can do to help you make this happen, give me a call. And so we did that, and I had people from 55 different institutions who decided to be a part of this. And it was all collecting those cards, or probably one or two I lost, but keeping most of them, calling them up, and really using them. And it was so helpful. And even we put together the protocol. We did the IRB, the Institutional Review Board. What do you guys call them?
MHC.
Okay, they know what that is. Okay. But basically, it's a way that a lot of the nurses and dietitians had never been in front of the panel before. And so it was a very good growth thing for them also. And then we did the clinical training. Basically, patients were very broad. They could be outpatient, inpatient. They could be benign or cancer. We didn't want to limit this, although that's how I developed it. We wanted it across the board. They had to be adult. Initially, they had to be able to read and or understand English. Spanish, we then added French because we had a group in Montreal. They could be either new patients or ongoing patients who'd been getting chemotherapy or radiation therapy. And if they had to have, we only asked for one evaluation, but if they had more than one, it had to be at least approximately a month, 28 days in between. Now, one of the things in oncology is we tend to like the scoring system of 0 through 4. Well, if that's what oncologists and surgeons and everyone is used to, don't invent a new system. Use 0 through 4. So that's what we did. And so 0 points was minimal impact on nutritional status. 4 points was potentially life-threatening. This is very similar to the common toxicity criteria that oncologists, nurses, everyone uses. And then 1, 2, and 3 were mild, moderate, or potentially severe impact in terms of nutritional status or risk. Now, how many of you have been involved with clinical trials of any type in the past? Show of hands. Okay. Patient recruitment can be a real difficult thing. Again, good idea, passion, and the right people. We put on, in a little over 6 months, 2,150 patients at 55 institutions. That's unheard of. Again, volunteer network. That's where that passion and idea makes a difference. The whole idea of an 80-20 rule, we had about 20% of the respondents were inpatient, including some in hospice, and then we had about 80% that were outpatient. Pretty much divided between men and women, regardless of age. That seemed to be pretty consistent. Now think of your cancer patients. What's the average age of most of your patients, would you say? 20s? 90s? 60s. Okay, and that's exactly what we found. We found just shy of a third of them were in their 60s, but we did have, remember this was both benign and malignant patients. Well, patients weren't required benign or malignant, but their disease was benign or malignant. We did have a small number of people in their 20s. Those were mainly the chronic disease, chronic kidney disease patients. And we actually had just shy of 1% that were in their 90s. So we really did have a broad spectrum of patients. We had multiple different malignancies that were represented, the two highest being breast and lung, which is not surprising. And then we also had 128, or about 6%, that were in end-stage renal disease on dialysis, and about a little over 1% who were on there because of their diabetes. What's interesting, and I know that the people in the Netherlands are much healthier and have better body composition than the average person in the States. Although I think that's also probably changing too, based on watching, the shows on television here talking about obesity, etc. But the reality is we tend to use BMI to define who's underweight, who's overweight, and who's obese. And this was done in the States predominantly. And we found that about 40%, regardless of gender, had a BMI in that underweight to not being overweight yet, okay? But that means that 60% of the people were overweight. So if somebody is 5'4" and weighs 200 pounds, whether they're man or woman, and they lose 10% or 20%, they're still not going to look cachectic. So just looking at them, if you start from an obesity, you can't do, in an obvious looking at them, the muscle assessment. You're going to have to do something a little bit different. So again, that